2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, the home of Neurosurgical TV. We have the pleasure of having the Walter Dandy Neurosurgical Club presentation, moderated by Abdel Rama Aliter. And today we have Orkhan Mammadkhanli presenting on the traumatic brain injury, the immediate management and long-term care. It's being moderated by the indefatigable Abdel Rahman Aliter, and I'll let him moderate. Welcome, Abdel.
Welcome. Walter Dandy Neurosurgical Club Yemen and Neurosurgical TV are honored to introduce Dr. Orkhan Mammadkhanli, a neurosurgeon at the Qatar International Hospital. We'll talk about traumatic brain injury, immediate management, and long-term care. Okay.
Very
Can
good.
I share my screen?
Yeah.
Can I share my screen?
Yes.
Okay. Okay. Can you see my screen?
Yes, I can.
Okay. Thank you very much for your invitation. Thank you very much, Dr. John Bennett, Dr. Ahmet Al-Ghanimi, and Dr. Abdurrahman Aliter. My name is Orkhan Mammadkhanli. Today, it's a privilege to join you on Neurosurgical TV, and we will explore both the acute management and the long-term aspects of traumatic brain injury. This talk is designed to be practical yet grounded in evidence to support your work, whether you are a student or a consultant. And here, what's your good planned for our presentation? This presentation will cover the most important things you can do now to manage TBI. We're also going to talk about the best way to treat TBI survivors based on what we know about it and how understanding of TBI treatment and care is changing. TBI is a major cause of death and disability globally. Affects all age groups, especially young adults and the elderly. Primary and secondary injuries determines outcomes. Each year, millions are affected by TBI worldwide. Road traffic accident, falls, violence remain the leading causes. And initial trauma, what we call the primary injury, is just the beginning. The secondary injury, cascade defines the patient ultimate cause. And how we need to classify TBI. For example, we can cause by severity. Everyone know about how we use a Glasgow Coma scale, and according to Glasgow Coma scale, we can divide into the three. Here you can see. Also, by pathoanatomic types, it varies from skull fractures until brainstem lesions, but most commonly we see the traumatic subarachnoid hematoma, also subdural and epidural hematoma. Also, it's crucial to understand the mechanism of TBI. It could be primary injury, it's direct mechanical damage, and secondary injury, which we can prevent. And as we can prevent, then we can reduce of extent of injury, such as ischemia, excitotoxicity, inflammation, and raised ICP. Also, before the next slide, I just want to remember to the neurosurgical residents that we have our cerebral edema is classified into two subtypes. It's cytotoxic and vasogenic edema. Cytotoxic edema occurs when the cells suffer an ischemic insult. Vasogenic edema results from disruption of blood-brain barrier. Cerebral autoregulation is the ability of cerebrovascular system to maintain constant cerebral blood flow over physiologic range in blood pressure. In patients with traumatic brain injury, vasomotor paralysis can result. They compromise their cerebral autoregularity capacity. Cerebral blood flow may dramatically increase, resulting in hyperemia. Increased cerebral blood flow results in elevated cerebral blood volume. And consistent with Monroe-Kelly doctrine, as the cerebral blood volume increase, the cerebral edema progress, CSF is displaced, followed by venous blood. If left unchecked, increased intracranial hypertension results in herniation, even and potentially death. That's why it's important for us. And next time, also how can we classify it by prognosis? Yani maybe you listen it or see previously by this. In some centers, they used statistical methods for the prognosis, but using these outcome models for exact prognostication on individual patients is not recommended. Why? Because the problem with many of these prognostic tools is that they were established based on population data and therefore cannot translate directly to an individual patient on case by cases. Also, there's problem with the subjective input of this clinician when trying to estimate prognosis, which can lead the self-fulfilling prophecy in which several TBI patients may receive less aggressive treatment due to subjective view of prognosis and therefore lead to poorer outcome. Also, you can see the essential columns of immediate TBI management. Just a minute, I couldn't switch. Okay, how will be our immediate management of TBI? In pre-hospital and emergency department care, we need to follow principles of ATLS. ATLS, what the meanings? Airway, breath, circulation, disability, and exposure. And after, we need rapid triage and transport patient. In patients with suspected or severe, moderate or severe TBI, we should transport it to the highest center level if they are available, ideally with neurosurgical capabilities. Also, we need to stabilize vital parameters. As I told before, we need to prevent secondary brain injury, avoid hypoxia, hypertension, hypercarbia, and hypothermia. Our treatment targets is this. In every hospital, with neuro ICU, we should firstly avoid hypoxia. Again, it's crucial. Maintain appropriate cerebral perfusion pressure. Normal carbia. Consider heat up 30 or 45 degrees. Avoid obstruction of venous return with C-collar, maybe sometimes there are also cervical trauma. Limit intrathoracic pressure, avoid excessive PEEP, ensure normal sodium levels because hyponatremia could lead to swelling of brain. We should avoid hypoglycemia and hyperglycemia. We should maintain normothermia and ensure seizure prophylaxis. We can directly start with levetiracetam, 500 milligram 2 days per 2 days day, at least 1 week. And there are maybe 2 conditions. In evidence of brainstem herniation, it's Cushing triad, and also signs of herniation if present, then we need as soon as possible decompress, but at this time we need to do this. Yeah, same principles, just here's written the exactly numbers. And if no evidence of brainstem herniation, we don't need to such much aggressively manipulate with the rheology of the blood, and we need stabilize the circulation. Again, sodium level SC, it's between 145 and 150. It's not exceeds the 160, because if exceeds the 160, then it could then we can have problem with the coagulation. Also, ICP monitoring, when we indicate indication, it's abnormal CV tomography, and if Glasgow Coma scale is 8 or less. Let's speak about the swelling, and here, if we summarize all of the swelling, here's the 3 tiers. Tier 1, normocapnia, analgesia, and sedation. Tier 2, EVD drainage, osmotic therapy, and paralysis. Also, Tier 2, craniectomy or pentabarbital coma, because surgery can be life-saving, but only when done at the right time for the right reason. Decompressive craniectomy remains controversial in some cases, but can be essential in malignant intracranial hypertension. And between these tiers, there are also in guidelines inter-tier recommendation. What's these inter-tier recommendations? That's re-examine the patient and consider repeating CT. Also reconsider about the surgical options. Consider extracranial causes. We need to check if there are any missing causes. Also consider consultation with higher level of care, if applicable. Also, a number of guidelines and clinical decisions rules provide indication for head CT in patients with suspected TBI. The American College of Emergency Physicians policy strikes a balance between sensitivity and specificity and recommends non-contrast CT in patients 16 years of age and older with loss of consciousness or post-traumatic anamnesis, and also if any of these following are present. And when we need immediate neurosurgical intervention, if in epidural hematoma, this indications is urgently, we need to operate as soon as possible within 2 hours of deterioration. This if the thickness of epidural hematoma more than 15 millimeters, volume of more than 30 millim, midline shift present and more than 5 millim, Glasgow Coma scale is less than 9. Also, this indication you see for the acute subdural hematoma, if regardless of Glasgow Coma scale, midline shift is more than 5 millim, or thickness subdural hematoma is more than 10 millim, significant mass effect and present, Glasgow Coma scale less than 9, And if the Glasgow Coma Scale decreased by more than 2 points from time of injury to admission, asymmetric or fixed and dilated pupil, or ICP measurements consistently more than 22 millimeters. Also, now I will show for the intraparenchymal. Intraparenchymal indication if the lobar bleed with mass effect and poor Glasgow Coma Scale. Consider early intervention irrespective of Glasgow Coma Scale if significant lobar bleed more than 15 mm³ or effacement of basal cisterns or herniation, posterior fossa and much more than 30 cm³, volume and mass effect, its brainstem compression, obliteration, fourth ventricle and effacement of basal cisterns. Other considerations, which also important in our practice, it's, for example, if the patient has secondary brain injury, or we need to use judicious vasopressors. What's the meaning judicious? It's use minimum required to maintain goal blood pressure. Because if the pressure will be low for the patient, then patient can have ischemia. But if we will increase much more than we need, then patient could have hemorrhage. Also, even despite we don't expect in such injuries, but also it could be vasospasm. Also, syndrome, inappropriate ADH syndrome, also crucial in the following these patients. Basilar skull fracture, pituitary dysfunction. Sometimes this patient could have several meningitis due to rhinorrhea. Also, what's the long-term our care and chronic management? We need to understand that our rehabilitation, it starts in ICU, and multidisciplinary care is essential. Physio, neuropsychology, occupational therapy. We need what? Sorry?
That's okay. That's okay.
Okay. Also, we need to assess risk of depression, post-traumatic stress disorder, and cognitive deficits. TBI care doesn't end with discharge. We must think with the long term of patient. Early rehabilitation, psychiatric evaluation, and social reintegration play huge roles in recovery. We need to initiate the rehabilitation early. Just a minute. Also, early intensive interdisciplinary rehabilitation improves functional outcomes. Therapy should begin as soon as patient is medically stable. Also, care transpositions. Patients unable to return home safely may require transfer to specialized inpatient rehabilitation or long-term acute care hospitals. Only a minority of moderate severe TBI patients receive comprehensive inpatient regulation highlighted in gap in care. Multidisciplinary care, coordination between neurosurgeons, intensivists, rehabilitation specialists, and allied health professionals essential for optimal outcomes. Here, I can show just two examples of traumatic brain injury. This patient, 59-year-old male patient, admitted to our clinic after fallen, and on the CT, he came with the loss of consciousness, and on the CT, on the neurological assessment, he has a Glasgow Coma Scale 8. So that's we intubate, and after stabilizing of the vital parameters, we check with the CT. On the CT on the left frontal lobe, we have contusion. Also, left temporal lobe, there are subdural hematoma. And if we assess the CT of the patient, there are no midline shift. There are all basal cisterns are open and no need for the urgent neurosurgical evaluation. So we just prevent the secondary effects like hypoxia, hyperthermia, and avoid the swelling, and checked in same patient after 14 days, and we see that nearly all of the blood is resolved. Now patients have Glasgow Coma Scale 13, but it's due to diffuse axonal injury, and we will check with the diffusion MRI when it will be possible. Also, we started our early rehabilitation. Also, I can show another patient. This patient was our nurse, our surgical nurse, 21-year-old female patient, admits to our emergency clinic after road traffic accident. When she came, she hadn't any, her Glasgow Coma Scale was 4. She was in herniated status. When we came, we see on the CT right frontoparietal and temporal subdural hematoma. Also, all basal cisterns is closed, and swelling of the brain, midline shift, right ventricle is compressed, and sulcal effacement. So we urgently, after stabilizing the parameters, we urgently took to the surgery. In the surgery, decompressive surgery, which open it with trauma flap, it's more commonly used approach. The patient is placed in supine position with the head rotated to the contralateral side, skin opened with the large reverse question mark incision beginning at the zygoma, extending posterior to the ear. It's approximately 4 to 6 centimeters, and then curving upwards, remaining 1 to lateral of the sagittal suture. The underlying temporal muscle and subcutaneous tissue reflected anteriorly and secured with scalp hooks. And after, when we open it, the brain, we observed that brain was severe swelling, and after dural incision, we removed blood. Also, I just put second photo to the remind that in this surgery, if possible, we need achieve temporal base for full decompression, or here should be at least 12 centimeters to 12, if possible 12 centimeters to 15 centimeters for the fully decompress of all the branches of the middle cerebral artery. Due to brain was severely swelled, we need put bone to the we need I'm sorry, we need to decompress and remove the bone. And after we followed the patients, after 6 weeks, when all of them solved, we have done cranioplasty. And these patients, last month, she sent me her picture. You can see on the right side. Now she hasn't any complaints, but she just, after trauma, she used levetiracetam twice a week. And we just following up. Yani, she came us with the Glasgow Coma Scale 4. And now she's again returned to the work. Even last week, we together operated. She was in our neurosurgery, not our neurosurgery, in spine team. Conclusion take-home message. We need to understand that early resuscitation and preventing secondary injuries saves life. Timely imaging and surgical intervention are crucial. Long-term care requires a multidisciplinary approach. And immediate goals: prevent secondary injury, brain injury by ensuring adequate oxygenation, perfusion, and ICP control. Early rehabilitation start as soon as possible for best long-term outcomes. Chronic care: recognize TBI as a lifelong condition requiring periodic reassessment and intervention. Multidisciplinary care: collaboration across specialties is vital from acute management through long-term follow-up. And please, if any questions, I can answer.
Okay, Abdel? Abdel, you're muted.
Yes.
Hold on, Abdel. Go ahead, Abdel.
What?
Okay.
Abdel is going to moderate.
I think it's enough.
Okay, here is a question. Thank you very much, Dr. Orkhan. We are honored to meet with you and to organize with you.
What?
Oh, can you try again, please? Abdel?
Okay. Thank you very much, Dr. Orkhan. We are honored to meet with you.
Thank you very much. It's also honor.
Okay.
Thank you very much.
Anybody have any questions on the panel? I don't know if anyone has any questions or comments on the panel.
Hello?
Go ahead,
Hello?
Fidelis. Go ahead, Fidelis.
Hello, can you take question from here?
Yes,
Hello?
please, go ahead.
No, there.
Okay, thank you.
Any question?
Okay.
Hello?
Yes.
Please, are you listening? Hello? Are you listening to me?
Yes, we are listening to you.
Yeah. Yes.
Okay. So a case of a 50-year-old man who fainted. I mean, he collapsed and hit his head around the occiput on the ground, and then sustained a mild swelling, and he had convulsion about 5 minutes after the incident, and he was rushed to a facility and assessed the GCS. It was 13/15, and the patient was stable. However, the patient was commenced on IV fluid, normal saline, and after a while, after about 1 hour, the patient started having convulsion, this time more severe. So please, what could be the better approach to a patient of this patient like this? Thank you very much.
Okay. Thank you for your question. As I understand, one patient came with the severe head trauma, and has an occipital fracture. Yes? Sorry, could you repeat? As it has occipital fracture and no underlying brain damage. Yes? Dr. Fidelis. Okay, I just how to say generally explain as I can. Firstly, we also need to add that also this trauma, it depends on the age, as we mentioned before, because it's if more than 65, it could be late hemorrhage, or these patients most probably use anticoagulants. So that's why every trauma, even in the same effects, could be different in the same patients. And if this patient has a seizure, then firstly we need achieve ABC, airway, breath circulation. It's crucial, and if we need to control the seizure, for the control seizure, after controlling seizures, and there are also some tired, like start firstly giving lorazepam and same time starting levetiracetam infusion, and it couldn't, then we need sedatize and we need intubate, and after check with the CTA why the patient has seizures.
Okay, CT, yes, yes, yes,
Yes.
yes. I think because our facility doesn't have CT, one of the reasons I had to refer the patient. So I think CT, yes. But could the patient at any point had any intracranial collection from that kind of trauma? Is it a likely thing, or what could have resulted in the multiple episodes of seizure the patient developed?
You know, if the patient has bone fracture, it means probably there are cup contusions and frontal cup contusions, probably. And we need to check with CT, because if in occipital, it could be in occipital lobe, or maybe if close to the midline, even there may be problem with the sagittal sinus. And we need the see patient, examine the patient. I'm sorry, I don't understand exactly your questions. Dr. Fidelis.
Oh, I guess he stepped away.
Okay. Question 2 من Thompson Sivla.
Thank you very much. Brilliant presentation, great work.
أيوة.
Okay, thank you very much, Dr. Tom Sivla.
Okay, very good. Okay, Doc.
Okay.
So what's up? What's up now? You're going back to work today?
Okay. Thank you very much, Dr. Orkhan. We are honored to meet with you.
Thank you.
Thank you, Doc, for taking your time.
Thank you very much for invitations. It really was exciting for me to see you and present today. Thank you very much.
Anytime. Thank you.
Okay, see you.